Welcome to the Step 2 high-yield review of pediatric pulmonary disease. We're going to focus on croup, epiglottitis, and whooping cough, as these respiratory infections have overlapping presentations, and differentiating them from each other is critical to getting questions correct on Step 2. We're going to finish with a discussion of asthma and its management, as this disease is becoming increasingly important in pediatrics every year. Let's start this section with a vignette. A 2-year-old is brought in by a daycare provider for a severe cough, fever, and runny nose. The child's cough sounds like a bark, and she's in obvious respiratory distress. Upon physical exam, the child refuses to lie flat, and chest x-ray shows a positive steeple sign. Your question is, what's the best next step in management? The most appropriate next thing you do for this kid? Your options are to intubate, racemic epinephrine, empiric antibiotics, acetaminophen, Tylenol, or a CT scan of the neck. So to decide what the most appropriate next step in management is, we need to figure out what the diagnosis is and how severe this case is. So a barking like cough is actually a pretty pathognomonic sign for some respiratory infections in children, as is the steeple sign on chest x-ray. And as for the indications of severity, we're told that this child's in obvious respiratory distress and that they refuse to lie down, meaning at rest, this child's in trouble. So with the barking cough and the steeple sign, we have a diagnosis of croup. And knowing that this is croup, the answer is B, racemic epinephrine. But even if you didn't know that with croup you get racemic epi, we can logically go through and maybe figure out why A, C, D, and E are wrong. So starting with A, the reason A is wrong is because intubate is something you do only in very serious dire circumstances. So croup is usually a subglottic inflammation. So it's in a part of the neck where there's bony structures around it that are going to assist in keeping the airway open. So you can try non-invasive measures to secure the airway before you intubate, such as using racemic epinephrine. Empiric antibiotics are wrong because croup first tends to be a viral issue. But even if this was a bacterial issue, you could argue that you still wouldn't give empiric antibiotics as your first step because this kid's coming in with respiratory distress, which means your focus should be on securing the airway and improving the respiratory distress. Antibiotics take time to work, so even if this was a bacterial infection, C would not be the right answer and you would still do some other measure to secure the airway. For similar reasons, D is wrong. While the child has a fever, fever is not the most pressing problem, and so you do not need to immediately give acetaminophen. And then E is sort of an oddball choice. Expect a few oddball choices on step 2, but in this case, there's no reason to think that there's physical obstruction, tumor, or trauma that requires additional imaging in light of the chest x-ray that we have. And the last key point I want to make in this vignette is not pointing out what you know to be correct and what you know to always be incorrect. Even if this vignette did not tell us that she had a chest x-ray and chest x-ray was an option, chest x-ray would not be correct. And that's because croup is a clinical diagnosis. If you clinically think a child has croup, the next best step in management is racemic epi. You do not need a chest x-ray to look for a steeple sign to then give racemic epi because the steeple sign you're not going to see all the time. So croup being a clinical diagnosis, even with or without imaging, you give racemic epi if that's what you think is going on. Let's review the upper airway anatomy for clarification. Here's an area of the vocal cords and the glottis. This is the ventricular fold. This is generally accepted where the glottis exists. Croup is a subglottic infection, which is why the more technical terms laryngotracheitis or laryngotracheobronchitis are also used in place of croup. That's because croup, the inflammation occurs below the glottis. See the little word larynx right there in the throat? So this is to differentiate croup from infections or inflammations of the supraglottic structures, which we'll discuss in a moment. And that's why you can see how wide the space is in the subglottic area as compared to the supraglottic area. And when we suspect croup, the answer to what's the next best step is racemic epi to open that airway rather than intubate, because you can see there are some bony structures down there which will help support the airway stay open even in times of inflammation. As noted, croup can go by either of the following two names, laryngotracheitis or laryngotracheobronchitis, and they have to do with how distal the infection involves. But what remains true of any case of croup is that it involves the upper airway and always remains subglottic. And that's important because that relates to what interventions we pursue in treating kids that come in with croup, and why we don't have to immediately jump to intubation and have the option of using things like racemic epi. Now, croup is almost always a viral syndrome, and the most common virus involved in croup is parainfluenza virus. RSV is a very distant second. Now, there are other viruses that can cause croup other than RSV and even parainfluenza, but step 2 is not going to try and get you to figure out the type of virus that a kid with croup is coming in with. Step 2 is going to focus on management and presentation. So knowing how to diagnose croup and then figure out the severity of the disease are key to getting the croup questions right on step 2. So starting with the diagnosis is croup, the step 2 children that come in with croup are going to have a triad of barking cough, coryza, and stridor. Now, the barking cough and the stridor in particular should sort of trigger a thought of croup in your head, in particular because croup is the most common cause of stridor in children, period. So stridor should immediately jump croup at the top of your list, and then you should look to rule croup out and think of other things. And the barking cough is there, then you got to go with croup. But the presence of stridor in and of itself doesn't tell you what to do because there are different management steps based on the severity of the croup. So you have to look for what's going to tell you how severe the croup is in this kid, and that is assessing the level of respiratory distress. Is this kid using accessory muscles? Are they tripoding? Are they refusing to lie down? All those situations, if they're present, will indicate severe croup and will change your management. Another piece of information is what you get on imaging. Now there's the steeple sign. So the steeple sign indicates severe croup, but even if you don't see the steeple sign, doesn't indicate moderate croup. So if you see the steeple sign, then that's going to be very pathognomonic for croup. But if it's not there, don't rule croup out. It's helpful when it's there. It's not really helpful when it's not there. And that, going back to what I said during the vignette, is keep in mind that if you have everything else that presents croup, you don't need to go forward and get a chest x-ray. You immediately move to treatment and management. Imaging is never the right answer as far as the next step. So how do you treat croup? Well, for moderate croup, you need anti-inflammatories. You want the inflammation of the throat to go down. And if it's moderate, you can use corticosteroids. But for severe croup, as we saw in our vignette, you want to use racemic epi and corticosteroids. And racemic epi works by vasoconstricting and reducing the swelling and edema of the throat. It also relaxes the smooth muscles of the throat, i.e. it bronchodilates. And then the corticosteroids are on board to avoid or sort of promote an anti-inflammatory situation of the throat long term over the next 6 to 8 hours. And there's also concern that you can have a rebound effect from racemic epi. So if someone gets worse 6-8 hours later, it could be the rebound effect of the racemic epi wearing off, not necessarily that it's not working. But in those who seem non-responsive to racemic epi, you have to worry that they actually have a bacterial cause of croup, which is not common. So really older kids that come in, and those who are unresponsive to racemic epi, those are the situations in which you start to suspect bacterial causes of croup. Moving on to our next upper airway emergency, let's go through another vignette. A 4-year-old child is brought in by a daycare provider because he is extremely irritable and refuses to eat. He also refuses to lean back, speaks in muffled words, and looks extremely ill, and he's drooling. Chest radiograph shows a positive thumbprint sign. So, like the previous question, what's the most appropriate next step in management? And to answer this question, just like last time, we have to pull out what the diagnosis is and get indications of severity. The answer choices are the same: intubate, racemic epi, antibiotics, acetaminophen, or a CT scan of the neck. Now, We know this kid's very sick because, like last time, they refuse to lie back. We're told they look extremely ill, and we're given an additional piece of information that they're drooling. Drooling is usually a fairly specific pearl used in tests to give one diagnosis in particular. And in combination with a thumbprint sign on chest radiograph, this is a diagnosis of epiglottitis. Now, knowing the severity of this disease and what epiglottitis means in a child, the answer is intubate. Now, epiglottitis is a severe, life-threatening progressive condition that requires immediate securing of the airway, and that's why we intubate. The most correct way to say this answer, which you might see a variant of it on the test, is to transfer to the OR and then intubate, because that is the more correct answer than intubating in your clinic or intubating even in the ER. Because if you botch the intubation in a kid with epiglottitis, you risk losing the airway altogether and having to do a tracheostomy. So the most correct answer is to transfer to the OR and intubate in those safe settings. B is incorrect because this is not going to be helpful in a bacterial infection like epiglottitis, as this is not croup. Now, empiric antibiotics are warranted, and we want to get antibiotics on board, but like we said in the last question, securing the airway is the most important thing to do right now, and the antibiotics are going to take time to work, so they are not the most immediate next step to do. Same thing with acetaminophen. Treating the fever is simply treating a symptom right now, and fever is not a great concern, so it's not the most immediate thing. And a CT scan of the neck, we don't need any more imaging beyond the chest x-ray that we got, giving us the information that we need. There's no reason to think that its CT is warranted. So the bottom line is that, like the previous case with croup, this is a case about securing and improving the airway status. But in the case of epiglottitis, that is usually bacterial, it's progressive and very dangerous, the best option is to intubate in the safest of settings. Returning to the anatomy of the upper airway, these arrows point to the supraglottic structures that are involved in epiglottitis. We have the epiglottis, we have the laryngeal part of the pharynx, and we have the aryepiglottic folds. Note how much narrower this part is, that the supraglottic space doesn't have as many bony structures around it in the throat to protect it in the cases of inflammation. And that's why in epiglottitis, there's a heightened need to intubate and to secure the airway, because once this area starts to swell, you can lose it a lot faster. Now to review the high notes of epiglottitis. Recall this is an upper airway infection. It's supraglottic, and for those reasons, it's an emergency. The most common causes tend to be bacterial, to differentiate it from croup, which is primarily viral. Classically, the bacteria most likely involved was an H. influenza type B, but in the age of vaccination, H. influenza type B has plummeted as a cause of epiglottitis. So only in your non-vaccinated patients should you immediately suspect H. flu type B in people who present with epiglottitis. And those who have a vaccination history, and it's good, streptococcal species and the non-typable H. flus are most likely to be your bacterial causes. But like in croup, in epiglottitis, I don't think you're going to get questions on step 2 that are going to ask you, what's the bacterial cause of this? They're going to be focused on the presentation and the management. And as we said, the presentation is where things can get tricky, and we want to be able to clearly differentiate this from croup. So like croup, this is going to present with fever and respiratory distress, but the drooling tends to be a pearl that's used in the vignettes to sort of differentiate epiglottis, to pull it away. And that's because the back of the throat swells so much that it's hard for them to swallow their own saliva, and it hurts like crazy. So the saliva pools in their mouth and eventually dribbles out. But they do have the fever, they do have the sore throat, but they do not have coryza. There's no itchy eyes, there's no runny nose, there's no recent history of a prodrome, because this isn't viral. Viral prodromes happen in viral infections. This doesn't have a history of a viral prodrome. It's a bacterial infection, and there's no cough. If you think about the anatomy of the diseases, if croup is a subglottic disease that involves the trachea and even the bronchioles, then yeah, you're going to get irritation of those lower airways possibly that can then cause you to cough. But there's no ciliated cells supraglottically, so you're not going to get a cough in epiglottitis. So if you can just remember the anatomy of the diseases, that'll help you remember no cough, and then you remember that what caused no cough and epiglottitis, and then if you remember what causes them, epiglottis is bacterial, so it's not going to have a viral prodrome and no coryza. That'll help you differentiate between epiglottitis and croup in those kids that present with respiratory distress and signs of an upper airway disease. Now, as far as the management of the disease, we've already gone over that, and that is transfer to the OR and intubate. You want to intubate in a safe setting, not in a clinic. And then antibiotics are going to be the next most immediate thing that you get on board, and that's because this is a bacterial infection, and you're going to use ceftriaxone or ceftriaxone. And I think these are important for you to know for your test. And then lastly, I want to say again, imaging is not required. Epiglottitis is a clinical diagnosis, just like croup is a clinical diagnosis. If a kid comes in that is suspicious for epiglottitis, you look in the back of their throat and you see a florid infection, you don't need to send them for a chest x-ray or a CT. That will never be the right answer. You immediately treat them for what you think their condition is. But you might come across the case in which they actually do give you an AP radiograph. And as you can see in this one, this kid has epiglottitis and has a thumbprint sign, as outlined by these yellow arrows. But like in real life, on your test, you should base your diagnosis and management on what you read in the clinical scenario. Pertussis is an infection with the bacterial microbe Bordetella pertussis. Unlike croup or epiglottitis, which can have many causes even if they each have their sort of predominant cause, pertussis is a one microbe show. This is an infection that produces the condition commonly referred to as whooping cough. Recall from your step 1 studying days that pertussis is caused by a gram-negative bacteria. It generally tends to be non-invasive and instead attaches itself to the ciliated epithelial cells of the bronchus, and as the bacteria produces something called pertussis toxin, that leads to ciliary paralysis of that part of the throat and ultimately inhibits the proper removal of secretions. Ultimately, that leads to a pretty good reason for a severe cough. Now, there are 3 main stages of pertussis infection, and we're going to go over a little diagram that properly outlines them. So let's use this timeline to outline the 3 stages of pertussis. Starting with the first stage, that occurs in the first 14 days, and is called the catarrhal stage. Now, this stage is your most mild stage. In the first 2 weeks where the bacteria has just entered the body, it's just starting to coat the ciliated epithelial cells of the throat, and the infection itself presents very mildly. They have your typical cold symptoms, congestion, rhinorrhea. This usually doesn't lead the kid to present to its pediatrician or the ER, and even if they do, the diagnosis can go unnoticed because it's simple and it's mild, and in vaccinated children or in a vaccinated community, pertussis might not be the top of the diagnosis. Because pertussis is so commonly associated with the whooping cough, we fail to realize that there's a whole stage that takes place before the whooping cough does. And unfortunately, it's this first stage that is most contagious. So in the first stage, where the symptoms are fairly mild, is when the children are actually spreading the bacteria to all the people around them. It also happens to be the only stage where antibiotics are helpful to the patient. So only if the child is lucky enough to have somebody to think that pertussis could be there and it's diagnosed, and they get antibiotics on board, this is the only stage where antibiotics are helpful. So the key factors you need to zero in on when it comes to stage 1. Mild symptoms, no whooping cough. They're the most contagious, and it's the only time antibiotics are helpful. Those are the key facets of stage 1. The second stage, on the other hand, is a prolonged stage that can last up to 30 days. It happens, but it definitely starts occurring after 2 weeks they've already been infected. Their contagious level has gone down. They're less contagious than they were, but now their symptoms are really kicking in, and it's called the paroxysmal phase. This is when the severe coughing fits kick in. The coughing fits are so bad and they're so prolonged that it causes them to whoop as they suck air in between coughing fits. They are also so bad that it leads them to vomit afterwards, leading to a phrase applied to them called post-tussive emesis. And a key facet is that there's no fever. So when a child presents with severe coughing fits, occasional bouts of vomiting, but no fever, don't think that doesn't mean they don't have an infection. Remember that Bordetella pertussis is a relatively non-invasive bacterial infection. It stays on top of the ciliated epithelial cells and uses its toxin to paralyze the cilia, and that's what causes the coughing, the inability to get rid of secretions. It's not invasive, so it's not leading to a inflammatory immunoreaction. That's why there's no fever. Fever is indicative of your body fighting an infection, but this infection stays mostly on the surface. So if you see the severe coughing and no fever, start thinking pertussis. There's a low requirement for admission, so that's when you see on step 2, they often say, what's the best next step in management? Admitting the patient is usually not the answer in pertussis. And then antibiotics do get prescribed. Now, we said in stage 1, we prescribe antibiotics to help the patient, and that's if they're lucky enough to get diagnosis with pertussis. But in stage 2, the purpose of prescribing antibiotics in pertussis is to prevent transmissibility. So if you get a question in step 2 that's going to ask about the utility of giving antibiotics, in the case of pertussis, if they're presenting at the point where they have severe coughing fits, which is the most common stage of presentation, it's actually to reduce transmissibility to the community. And the last stage is simple. It's the last 2 weeks of their infection. It's called the convalescent phase, and that's when their symptoms start to resolve over a prolonged period of time. They continue to have coughing problems, but they have less whooping and less respiratory problems in between coughing fits. And here's a review of what we've already said about Bordetella pertussis now and whooping cough. And I just wanted to give you the 3 stages in a bullet format if you'd prefer that. I want to highlight the paroxysmal stage because that's when patients most commonly present, and that's because that is when the severe coughing fits take place and the post-tussive emesis occurs, leading mom and dad to bring the kid in for an evaluation. And recall that you can give antibiotics in this stage, but it's only going to reduce transmissibility, and it's really not going to help their infection resolve faster. Now, for the diagnosis of pertussis, it is a clinical diagnosis. That's the same thing that's true of croup and for epiglottitis. Now, how is that important to you on step 2? It's because everything you need to diagnose pertussis is going to be the words that are in the vignette. If they don't give you a chest x-ray and they don't give you a PCR, but the clinical picture sounds like pertussis, that is your clinical tool to diagnose it. That's all you need is the clinical diagnosis. So the answer for what's the next best step in a patient that presents with a pertussis-like diagnosis is never going to be get a PCR or get a chest x-ray. You don't need them. You only need the clinical information. Chest x-rays are helpful and PCRs are useful, but remember, it's the words in the vignette that you need to diagnose pertussis. The management of pertussis is actually very important, and it's not exclusive to the patient. It's primarily supportive. If they usually present in the paroxysmal stage, and you usually just support them and make sure that they're hydrated, they can respire effectively. But if you're lucky enough to catch a patient with pertussis in the catarrhal stage, then we treat them with azithromycin and erythromycin, and everybody gets it. So any patient that presents with pertussis, regardless of stage, gets these antibiotics, but that's largely to prevent transmissibility. If they happen to be in stage 1 of pertussis, then it will help ameliorate their own disease. But any stage, they still get the antibiotics. So putting your step 2 frame of mind on, any patient that presents with pertussis is going to get antibiotics, but the reason they're getting the antibiotics will be different depending on the stage that they're in. If it's stage 1, they're getting the antibiotics to help themselves and prevent infection to the people around them. But if they're in stage 2, it's really only to prevent infection to the people around them and isn't really going to help them that much. As far as close contacts, we give macrolide antibiotics to all family and friends that have had contact with the patient, because the infection rate among those living in the same household can be as high as 90%. So therefore, you could think of a triple step question that step 2 could give you, that as a patient that presents with an unknown diagnosis, which you'll make as pertussis, but the question then asks you about sick contacts. There are only a few infections that require prophylaxis to close contacts, and in the case of pertussis, it's macrolides. So you haven't done it already, whip out a post-it or a piece of paper and make a list of the infections where prophylaxis goes to close contacts. And I'll give you a freebie, and it's bacterial meningitis with Neisseria gonorrhoeae. That's another disease in which you give prophylaxis treatment to close contacts of those who have it. Now, as for the community, we participate in vaccination campaigns anytime there's a bout of pertussis because it's, as we've said, it's highly transmissible, and the best way to prevent pertussis in the community is to adequate vaccination. Now, this is a good time to take a short segue into looking at the most common viral infections in childhood, because there's a specific group of infections that are really mostly seen in kids that have multiple different presentations and have specific questions on what the best test is in the beginning versus the most accurate test, but you'll see a lot of commonalities as we go through. So the first one is varicella. Now, varicella infection, you probably know a lot of people who've had it. If you haven't had it yourself, it's a highly pruritic vesicular rash that has, it's multi-generational rash, meaning that different crops of the vesicles across the body look like they're at different phases. It starts in the face and it's preceded and accompanied by fever and malaise. The best initial test is a zinc smear, which is also seen in other herpes viruses, but the most accurate test is going to be culture. Now, it's unlikely that someone's going to actually culture varicella because the treatment for it is supportive. If you think someone has varicella, the question is, why would you culture it? Because what else do you think they have? So you're probably not even going to take a zinc smear or a culture, and you're just going to provide supportive treatment unless they start to decline. Because varicella rash doesn't look anything like other more concerning rashes like measles. Now, measles is preceded by the 3 C's, the cough, coryza, and conjunctivitis. And then they have this exploding rash that starts in the head, and it looks like someone dumped the rash over them, and it just goes from the head down to the trunk and across the torso. They also develop Koplik spots, which are white spots with a sort of bluish center right in the buccal mucosa within the mouth. Now here's the key feature. It's a clinical diagnosis. The initial test, clinical. If you think, and that's because it's sort of like saying there's a low threshold for if you think someone has measles, you act on it. And that's because measles is highly contagious. And, for every one person who's infected, they can transmit this infection to 20 other unvaccinated people. And that's why we have such strong vaccination campaigns in this country to keep measles vaccination high. But a definitive diagnosis will require IgM antibodies for the presence of an acute recent infection. Unfortunately, measles can be deadly, and the treatment for it is only supportive treatment. Now the next is 5th disease with parvovirus, and this is when the children present with fever, UR symptoms, and slapped cheeks. Now another major feature of this virus is that they also might throw in an adult who presents with, maybe some achy joints. They don't have the slapped cheeks rash, but they're complaining of sort of a diffuse arthritis that or arthralgias they've never really had. Not necessarily arthritis, but the symptoms that sound like arthritis, and they've been temporary. That's because parvovirus presents in adults differently the way it does in children. They don't get the slapped cheeks rash. Either way, it's a clinical diagnosis and supportive treatment. But there is a concern that these kids or adults can develop an aplastic anemia. So you should make sure to always take a CBC on them to follow up and make sure that they don't have bone marrow issues. Roseola is probably the least exciting of these 5, and it's just a very, non-specific rash, fever, and upper respiratory prodromal symptoms that progresses to this diffuse rash. And again, it's a clinical diagnosis, and it's mostly picked out by not having features of the above viruses. So it doesn't have the classic measles distribution. It doesn't have the Koplik spots. It's not itchy and vesicular like varicella. It's not slapped cheeks. So you end up with just roseola. And it's
doesn't cause a lot of damage in children. And then there's mumps. Now, mumps is a fever that precedes parotid swelling bilaterally, and that can progress in young boys to orchitis, which is swelling and pain in the testicles. And this is also a clinical diagnosis because there aren't many things that's going to present with the swollen parotid glands, and it's just supportive treatment as well.
Asthma is an important topic to understand, not just for life, but for your test. And that's because the differential for a child presenting with cough and wheeze is broad and therefore easy and great to test. And it's the most common chronic disease in children and therefore incredibly likely to show up on your test in some form or another. Now, the pathophysiology of asthma is very well understood. The first component of it being reversible obstruction, meaning that we can pharmacologically reverse the obstruction in asthma, something that's not true of other obstructive lung diseases like COPD or emphysema. The second component is hyperresponsiveness. This is a joint contribution of the airway to be both overzealous in its airway constriction with delayed relaxation when it's responding to triggers, something that's not seen in people who don't have asthma. And the last part is inflammation, and this is where the real damage takes place. There's both an acute and chronic component to the inflammation of asthma, but the chronic inflammation is what leads to the devastating, irreversible remodeling of the airways that leads to chronic problems related to asthma. Unfortunately, when it comes to diagnosis, we don't have a single diagnostic marker that allows us to say you do or don't have asthma. So the diagnosis often depends on clinical signs, and that's how you present, what are your symptoms like over time, how do you respond to these medications. That's the best way to diagnose asthma. And so a lot of your questions on step 2 are going to be more vague contexts of these asthma patients. How are they responding to their inhalers? What is the progression of their symptoms? And then it's going to be, what do we do in the case of asthma attacks? Chronic asthma is tested more often than acute asthma when it comes to the test because there's an established algorithm for how you build up medications, which we'll go over in a moment. Something that is utilized often in the diagnosis of asthma, but more often in adults, is pulmonary function test, PFTs. And that's because PFTs can give you a marker of how bad asthma is, but usually best used during an attack. They're not particularly helpful in children because PFTs, if you've ever seen them done, are dependent on effort and an understanding of the test. And both of those can be low in children or can even be low in adults. So if PFTs aren't helpful, there's other things you can use. But if in the case in which you do see PFTs, you should lock in PFT in asthma with decreased FEV1 and decreased FEV1 over FVC ratio. Those are the signs you see on PFTs in an asthma patient while they're having asthmatic problems. If there's no PFTs available, something that can be used in children is called bronchoprovocation with methacholine or exercise. This is in which we test the hyperresponsiveness of an airway by giving them something or requiring them to do exercise. And if they have the hyperresponsiveness, that's an indication of asthma that's not seen in many other lung diseases. And then lastly, a chest x-ray can be useful to exclude other non-asthmatic diagnoses. And during an attack, chest x-rays often show some hyperinflammation of the lungs. You'll start counting ribs and you'll get maybe 11, 12, 13 ribs on an hyperinflated chest x-ray of an asthmatic patient. Now, the treatment of asthma is where the money is at for step 2, because the most complicated yet practical question you will get is to identify the severity of a chronic asthma patient and decide what treatment is required given their symptoms. The medications are as follows. So step 1 is really, when it comes to treatment in asthma, is not even a medication at all. It's avoidance of triggers. So if someone comes in with one little attack a month, you just got to help them figure out what's causing their attacks and tell them to avoid it. Then it's short-acting beta agonists, inhaled corticosteroids, long-acting beta agonists, and leukotriene antagonists, or modifiers is another term that's used. The real question is, when do we use these medications? How do we use them? And when do we escalate therapy? A common way step 2 is going to ask you about asthma is they're actually going to give you a vignette and they're going to tell you the patient has asthma. And the question is going to be, given the medications they're already on, what do we do now? So you have to understand which medications come first, what's considered escalating therapy, and what's an acceptable, tolerable amount of asthma symptoms. So if somebody comes in with a history of being on their albuterol inhaler but still using it 6 times a day and waking up 3 times a night coughing, they need to escalate therapy. The question will be, what therapy do they escalate to? And that's what this diagram is going to show you. So every asthma patient starts with a short-acting beta agonist as needed, their PRN albuterol inhaler. So they'll use that only when they need to, and they shouldn't use it more than a couple times a day. If they are, they escalate to low-dose inhaled corticosteroids. That means if they're in the second box, they both have the short-acting beta agonist and they have daily low-dose inhaled corticosteroids. After that, you start moving up the scale, and you still have the short-acting beta agonist inhaler as needed, but you start adding long-acting beta agonists, or you start adding the leukotriene, or even up your dose of inhaled corticosteroids. You're not doing everything in this middle square. You're doing one of those things. And if that doesn't work, high-dose inhaled corticosteroids and a long-acting beta agonist. So this is somebody who's really not doing well, having many coughing fits at night, can't get through their day without using their inhaler frequently. And then lastly, it's high dose, the long-acting beta agonist, and even oral steroids. Oral steroids is the end of the line asthma treatment. This is what you've got to do when you're giving oral corticosteroids, and it's really uncontrolled asthmatic. So this is going to explain everything you need to do when it comes to escalating therapy, and the whole point is that as symptoms get worse, you're going to use more medications. So that ends our Step 2 high-yield lecture on pediatric pulmonary disease. We covered croup, epiglottitis, and whooping cough, and asthma. Remember that all these are clinical diagnoses. There's no single marker test that's going to diagnose it for you. And you only need the words in the vignette to diagnose them. And then given the severity of the disease that you're presented with, that's going to guide your management, as they all have different management steps based on their severity.